Okay, so thank you very much. So let's move forward to our last session for today, conference. So we have 1 hour presentation for 2 speakers, likely 25, yes, 25 minutes. Okay, so hello, are you okay? Perfect. So our first speaker is Dr. Liu. So Dr. Liu is the Chief Scientific Officer and VP of Research of the University of Ottawa Health Institute and Professor of Medicine and Physiology at the University of Toronto and Ottawa. So he is the former scientific director of the Institute of Circulatory and Respiratory Health at the Canadian Institute of Health Research and inaugural director of the Heart and Stroke at the University of Toronto. So he received his medical degree from the University of Toronto and postgraduate training at Harvard University. So his laboratory investigates the cause and treatment of heart failure, role of inflammation, and identification of novel biomarkers and targets for intervention in cardiovascular disease. So listen to this. He has published over 350 peer-reviewed over 500. So usually, if you are, I would say, a productive researcher, so it could be like around 150, 200. You see? He is not retired yet. So we'll continue to publish maybe over 1,000. So today we have the privilege to have you, Dr. Liu, so talking about COVID-19 vaccine uptake among ethnic communities in Ontario. So thank you very much.
I have the special privilege today of sharing some new data, and it's a project funded by CIHR and very much supported by Professor Cénat. And so he hasn't even seen some of this data, so it will be actually really hot off the press. And but at the same time, would like to get your input, and so some of the discussions so far are really excellent. And so this is a real privilege for us to be able to share this with you. And so just a background, and then of course this has been well talked about already, and that is that we do know that COVID vaccine uptake, has been challenging in the beginning, but ultimately has been a success. And I will focus on data in Ontario because we are able to get the entire Ontario population data in terms of vaccine uptake. And but we also know that there are concerns about the vaccine. And for example, one area in which that's involved the heart is the vaccine-related myocarditis, which of course gets very much exaggerated, on social media, and actually contributes to the vaccine hesitancy. But what is actually the data? And does myocarditis affect the racialized community more or less? Does that actually warrant some of the hesitancy that we do see? And then we try to do a deeper dive, in terms of doing survey amongst the different communities that include the South Asian, Eastern Asian, Black population, and try to get the insight and to see, in fact, there are similarities and differences compared to, say, like the white Caucasian control groups, and then whether there are lessons learned. And so a lot of this actually echoes and mirrors the wonderful work that's already been presented. And I'll talk about two studies. One is an epidemiological study. It's a big data project in which we actually try to collect the entire vaccination data in Ontario, and particularly looking at the first rollout and the second rollout of vaccines, and look at the rates of uptake, particularly in this case, looking at the East Asian and South Asian populations. And then we look at the rates of myocarditis in these populations compared to the general population, and then look at the survey data to get a little bit of insight into this process. So in terms of the large epidemiology data, and what we try to do in terms of objectives is really actually look at the rates of uptake over time amongst the three groups of folks that we are focusing on. One is the East Asian, one's the South Asian, and the other is the control population. And whether there are any differences in rates of uptake, from the entire population point of view, and what is the rate of myocarditis, which is one of the major concerns. And so we use the Kaplan-Meier methods. We have the ability to actually capture all the individual health data in the province of Ontario through ICBH data linkages, Ontario Health Data Platform. And then we also linked onto the COVAX registry, which then tracks all the vaccines that's actually given across Canada, really, but the COVAX Ontario allow us to track all the vaccines that's given in Ontario, so we can actually link the vaccine data to the individual data, but also look at the outcomes as well. So this ultimately allowed us to look at entire population of 10 million individuals with the health data that's available, and but out of these, we also used the AI-driven algorithms. This is using surname as the initial driver to look at identify East Asian and the South Asian population. We couldn't do this with the Black population, even though this is something we like, is because the surname algorithm has not been able to be validated in the Black population, but it's over 95% accurate for the East Asian and South Asian. That's why we use this algorithm to capture most of the individuals. So in the end, we were able to end up with about 500,000 eligible Chinese population, as well as over 400,000 South Asian population, and then track the vaccine uptake. And so this is really actually the kind of I just put a summary slide essentially. And what you can see from here is that from day 0, which we put in as a December 1, 2020, that's kind of vaccine just became available. And Canada, I think, was able to get the vaccine into the country around mid-December. That's kind of the first vaccine available. And then, the rollout. And so you can see that I know it's a little hard to see here. Let me see if I can point out. And you can see that, there's a fairly rapid uptake in all the populations. So the red color is the control, the general population. And no, I don't know. I guess this is black color is the Chinese. And the blue color is the South Asian. And what you see here is that, in fact, the general population was able to take up the vaccine earlier than the ethnic communities, just slightly, but it's very statistically significant. And so there is a lag initially in terms of ability to actually get vaccinated. And so keeping that, this is, sort of a Kaplan-Meier, this is, sort of the proportion of population being vaccinated over time. So this is the date over time. And you can see that the most rapid uptake is around 180 days, so which is around May and June. And that's when, the vaccine become more very much available in the general population. And then, ideally, you would have 100% uptake, right? But of course, that's not possible. But what you see that there is actually rapid uptake initially, but more rapid, amongst the general population than the ethnic groups. So there's a lag in the ethnic group. But over time, though, it's actually the other way around. You can see that ultimately, the red color, the general population settled around 80%, and that becomes asymptomatic, whereas the the Chinese or East Asian and South Asian population, in fact, exceeded that. So there's actually a catch-up phenomenon over time, and which is very interesting in that there's obviously because there was actually some focused effort, in terms of vaccination in the communities. So I think it's interesting data to ultimately look at. And then the other, that was the first tranche of vaccination. What about the second dose? When you actually look at the second dose, which is the booster, most people kind of got it in between 3 months to 6 months and things like that. And so you see that the lag effect is actually much less, which is nice, so that obviously, the ability to access becomes much better. But again, you can see that the ethnic community end up actually having better vaccination rates, certainly in the East Asian and South Asian population, right? Compared to general. So some very interesting kind of data. This is the entire population for Ontario from that point of view. But there are some concerns, regarding the fact that vaccine may have side effects, right? And the myocarditis one is one that talk about the most. Because we work in this area, we have the National Registry of Vaccine Complications, myocarditis, especially from Public Health Agency, and I guess social media attacks all the time in that I'm hiding data. There are way more people having complications. But in fact, when you actually look at the rates of myocarditis, which is very, very low to start with, and that you can see that, out of the 9 million general population, the rate of myocarditis is about 51 per 1 million dose. So just think regular myocarditis in the population is actually anywhere between 3 to 10 times that. So the rate is actually very low from the vaccine point of view. But the interesting thing, however, is that you look at the Chinese or South Asian, the rates are actually lower. So the thing is that, in fact, these complications are actually lower in the ethnic community, whereas, quite often that's not the case, right? Because the popular literature tends to say that, we're going to actually, have a lot more risk, compared to the general population. So, I think data ultimately is actually very useful. But it is true generally that keep in mind when you have the vaccine-related myocarditis, it's more common in the younger population. Generally, it's in patients under age 30, and more common in males. So this is peculiar to the mRNA vaccines, and this is similar to the second dose as well. There are differences, amongst the vaccines, and this is quite consistent whether you look at the general population or the ethnic groups. And in that, the Moderna vaccine, which is the one in the middle, actually have much higher risk of myocarditis. I think this is generally known. Moderna, being a smaller, newer company, even though it has Canadian roots, didn't want to take any chances. So they really actually put in a lot of mRNA into their vaccine dose. So their dose is generally about 3 times higher than the Pfizer vaccine. So it's actually very good. Some folks may, experience a little bit more side effect from the Moderna vaccine, very protective, but also the risk of myocarditis is slightly higher as well, so it really actually tracks very clearly. Now, in terms of survey, we then also followed up with the survey of the 4 groups of racialized communities that include not only East Asian, South Asian, but also Black population, and compare with the white Caucasian controls. And I'm very jealous that you folks have way more sample size. We only had it's about 1,200 patients and individuals, so about 250 in each group in terms of getting the survey. And so in terms of so we're interested in terms of the general perception of preventive strategies in the setting of COVID, and then in terms of the actual vaccine uptake and the challenges that people may face. And so we're following up, after the survey, now doing the focus groups, to get the in-depth study. And so we co-designed actually the survey. So what we did was actually we got together with each of the community leaders, and also healthcare providers, in that community, as well as individuals. And so we actually have the survey co-designed, and so that it is relevant and it does actually address some of the concerns, for example. And then we translated it. We had enough money for 10 languages, but you'll see that, in fact, I was mentioning earlier, the population just from this group of survey come from 50 different countries. This really shows the diversity of Canada, right? It's really just amazing. And so in the end, we end up with 269 East Asian Chinese, 267 South Asian, 267 Black, and 250 white Caucasian. And so these are, I would say, it's like a cluster randomized recruitment process. So we did actually work with, for example, community leaders. We worked with religious leaders. We worked with some of these are really kind of clubs and other communities in which they get together. Some are, sort of places where people shop together and things like that. So that these are, and then we get the permission, and they recommend that sort of individuals, and we select randomly to participate in the study. And so in terms of the baseline demographics, so in fact we have the participants ranging all the way from age 18 to the oldest individuals, I think it's 92. And we really actually make sure we have a wide age representation, but the average or median age is around this, between 30 to 40, you can see. We do have more females than males in this sampling, and quite often this is a volunteer pattern. And then in terms of about 50% were married, but the rate is lower in the Black population. Could be because they're younger as well. And then, but it's interesting when you actually look at the proportion that's born in Canada, that they're native Canadians. Generally, the rate is between 20 to 30% in the ethnic groups, whereas the white Caucasian group is 85%. So it really actually shows a very significant difference from there. But also really shows that at least in these two centers where we recruit patients from Toronto and Ottawa, that there is a very large immigrant contribution. And the other thing that's really interesting is actually, I was mentioning earlier about the languages, in which we translated the survey into. And so if we see that in the white Caucasian population, that majority English speaking, and a significant proportion of French speaking, and so these are the dominant languages. Versus, for example, if you have East Asian Chinese, so they're about 22% actually English speaking, likely representing sort of a second generation or beyond in terms of that racial group. And about a half spoke Mandarin, half spoke Cantonese, kind of what you expect, in that population. But on the other hand, South Asian, I assume that everybody will speak English as first language, but that's not true at all. In fact, only about a third is, in fact, use English as a primary language, but actually we do have folks speaking Hindi, Punjabi, Urdu, and many other languages. It really actually shows the heterogeneity. And in the Black population, 50% spoke English, but there were other languages as well, in terms of French, as well as Somali. And but there are many other languages. In fact, we have sampling from many countries, in Africa, many countries, from the Caribbean, so South America, but there are also first generation blacks as well. And so if we actually look at the health profile of this group, and you can see that, in fact, at least the folks participating in this study, practically 100% of them all had exposure to COVID. So this is just how common it is, but certainly may represent their interest in participating in the survey as well. But the other aspect is, as we mentioned to Professor Cénat earlier, that we begin to use this as a tool to study chronic disease, and the challenges in terms of health access and things like that. And so indeed, when we also explore factors like hypertension, diabetes, and other factors, it's interesting that the self-declared hypertension is actually relatively high in some groups. So in terms of the East Asian Chinese and South Asian, 20%. Now, general population is about 25%. So this is actually quite high level awareness. I was quite surprised at this. And but on the other hand, the other groups in terms of black 11.6% and white 8.5%. So they may represent sort of under awareness of these conditions. The surprise that I had was that we also had questions on mental health. Do you actually experience mental health challenges? Are you depressed, anxious? So many of those type of questions. And so the frequency is actually around 10%. And so this probably is at least, this is self-declared, right? And it could be actually even higher than that. And but the other aspect is in terms of the sort of health access. So private insurance is available between 30 to 40% of the ethnic communities, whereas 2/3 in the white Caucasian population, right? You can begin actually to see that difference. And then how about the lack of family doctor, which is kind of a real common problem. And so you can see that for the ethnic communities, anywhere between 20 to 30%, whereas somehow we got more privileged white Caucasian sample, only 8.4% have no primary family physician. But it really actually does reflect, right? There are differences in terms of health access just from this sample, sort of in the real community that we live in. And then in terms of trust, so that was a fantastic discussion on trust. And so I just give a very high level kind of summary of some of the questions related to that. But it's trust in preventive measures, so, what do you think of the various preventive measures to mitigate, the risk of COVID-19? So in fact, so the interesting question obviously is what do you think of vaccination? And so you can see that in terms of vaccination, the East Asian Chinese and South Asian, in fact, at least comparatively speaking, were more trusting, right? Compared to black, but in fact, the white Caucasian were the most distrusting of the vaccine. So this is a really kind of interesting, sort of information. And how about looking at the masking? So in terms of having masks to prevent, and so you can see that the East Asian are most trusting of masks. Versus, the white population actually don't think masks, or certainly don't think as much in terms of the value of the mask. And avoiding crowds, similar type of pattern. And so here is the real, proof in the pudding. How about following public health agency recommendations, about, sort of the governmental recommendations. And again, certainly there's a decrease overall, and but particularly in the black population and also in the white population. So I think there is obviously, sort of challenges of in terms of getting the message, right, to action, right, so there is actually that concern that folks talk about very much earlier already. And then even though, so this is interesting, even though there's not so much enthusiasm necessary thinking the vaccine is the most important, but in fact, this group were actually very much probably self-selected some way. In fact, over 90% of the sample all had vaccine, at least one dose. But however, the number of doses in terms of peak is different in that in the East Asian Chinese, the majority of the people have 3 doses at the time sampling, which is about half a year ago. Whereas South Asian, generally 2 doses, black population, 2 doses, and the white population, 3 doses. And so you can see that the number of doses that's actually begin to play a role. So now, what about barriers in terms of accessing vaccine? So we are kind of happy to see that even though there is a potential, sort of question about the value of vaccine, but there is actually reasonable uptake. But what are the barriers? So if you can actually see, sort of a potential ability to take time off work in order to get the vaccine, and between 13 and 16% for the Asian population, but 25% in the black population, versus only kind of less than 5% in the white population, right? You can actually see that there is actually quite a lot of challenge. There's another question which is interesting. How many jobs do you actually hold during COVID in order to make ends meet, right? It's follow the same kind of pattern, right? The black population are the ones who really have to, sort of do multiple jobs in order to keep the, sort of the finances balanced in the family. And the other challenge is actually the language, which was a bigger surprise for us. So that is that in order to access vaccine, what are some of the challenges? Is the language access, because a lot of these are kind of booked online, and so you can see that in terms of languages, so it's between 40 to 50%, whereas obviously this is much less of a problem in the white population. And how about technology? And you can see that again, this is a challenge, less in the black population by comparison, whereas this is not the case in the white population. What about transportation? To get to the place where you can get vaccine, and you can see that the black communities have the biggest challenge. And of course also the work and really there are a lot of kind of socioeconomic barriers, in this type of setting. And so I think this is really actually kind of underscores, many of the, I guess, social, inequities that actually leads to some of the patterns that we see. So just to finalize as a summary then, so we can see that during the first dose rollout of the vaccines, the different communities, certainly the racial communities, initially lagged behind the general population, but subsequently actually exceeded. So it does suggest that the targeted, sort of rollout of vaccines can be effective. And so this is, I think, an important something, sort of a lesson to learn. And by second dose, this lag is already disappeared. So obviously the system is now working reasonably effectively. And even though there was a concern about, communities may actually have higher risk, but in fact the reality is that the complication rates certainly in the South Asian, East Asian groups are actually less in terms of myocarditis. In fact, now there's a good data to suggest that it's actually the white population that actually tend to have the highest risk for myocarditis. And but we do see that there is some lack of trust in terms of vaccine efficacy, particularly in the black population, but also in the Caucasian as well. And but there are definite, sort of social and work-related barriers and technology, language-related barriers in the ethnic communities, compared to white. And so these are things that definitely needs to be addressed for us to really, have a much more equitable outcome. So just like to thank everybody, and thanks very much, to this team here. Thanks to Professor Cénat's support to make these studies possible. Thank you so much.
Our last speaker is Dr. Cénat. So, as you know, donc Jude est notre vedette, n'est-ce pas, hein, pour la journée. Fait que alors, Une brève présentation. Donc, Dr Cénat est professeur agrégé à l'école de psychologie, donc directeur du Centre interdisciplinaire pour la santé des Noirs et du laboratoire de recherche vulnérabilité, trauma, résilience et culture à l'Université d'Ottawa. Donc, son programme de recherche explore les facteurs associés à la vulnérabilité, au trauma et à la résilience avec un intérêt particulier sur le rôle des facteurs culturels. Donc, Dr Cénat mène des recherches sur les disparités raciales en santé mentale et dans les services sociaux, l'impact des catastrophes naturelles et des maladies infectieuses sur la santé mentale, les traumas interpersonnels et non interpersonnels et la santé mentale mondiale. Alors, aujourd'hui, donc c'est lui qui va clore la série de présentations avec, disons, sur la confiance, la méfiance et la prise des vaccins contre la COVID-19, littératie en santé, théorie complotiste et discrimination raciale au sein d'un échantillon représentatif des groupes ethniques au Canada. Donc, la vulnérabilité des personnes arabes, autochtones et noires. Merci beaucoup.
So I can take 1 hour because I'm the last one. That's good. As Madzi said, we started with a paper on vaccine hesitancy in Canada, vaccine hesitancy and vaccine unwillingness in Canada. And after this paper, what we saw is the fact that we did not have enough disaggregated data by race. And after this data, we wanted also to know what is the situation specifically in Black communities. And I can tell you, at the end of 2022, even we know all what we know about the Black communities, there were just 5 papers presented data on Black communities, and all of them just on 247 Black people, so which was, I can say, unacceptable. And this is why we titled that paper about the failure of researchers in Canada to address vaccine hesitancy in the Black communities. It is important to note that Black communities are the community with the highest rate of mortality according to COVID-19. So it was something that is important. And then we had the project where we were able to recruit more than 2,000 Black people across Canada. 7 provinces where 98.3% of people from the Black communities are living. And that showed us that Black people are really vulnerable about vaccine hesitancy, vaccine mistrust, but also they have less confidence in vaccination, and also the fact that there are a lot of factors related to vaccine uptake, and racial discrimination was one of them. But one of the things that was also very important is the fact that we had one of the most important critique we have when we try to publish that data is the fact that the reviewers said you don't have a group comparison. So what about the other groups? Myself, I think it is important to have comparative research, but also it is important to have research in each group to be able to do it deeply and explore the factors deeply. And I think that it is also something that is important. So then we had the project funded by PHAC, the second project funded by PHAC, and we were able to collect data on more than 4,000 people across Canada. And in that people, what we did was also to oversampled people from the Black communities, Asian communities, Arabic communities, but also Indigenous communities. And it was important for us to oversample them because that will allow a lot of things. First, to be able to really study that population separately, but also to compare what is the situation of of the global population. And it was also important to note that we had a great white sample in that for that data. We explore a lot of things, and today I will only present really the first preliminary analysis, because we just submit one paper and we just finished another one, and we put our times to really try to from now to June, we said we're supposed to submit at least 10 papers. We hope we will be able to do it. And we are working on the papers, but the most important is, for me today, was to present vaccine mistrust and vaccine uptake. So for vaccine mistrust, what we saw was the fact that people from Black communities are those who have more vaccine mistrust. The score was higher significantly higher in Black communities when compared to white communities, also to Arabic communities, but also Asian communities and Indigenous communities also. So we can see the vulnerability of people from the Black communities, people from the Indigenous communities, people from the Arabic communities and Asian communities when it comes to talk about a vaccine mistrust, COVID-19 vaccine mistrust. And then we, for educational level, I wanted to present this because you can see the difference. And what is the most important for me is in the highest level of education, there is no significant difference between the communities. And I think it is something that is interesting to see, and to see people with a graduate level. So then you don't have differences. And I also wanted to talk a little bit about this model, because when you take this model, what we found is the fact that conspiracy beliefs is the most important predictor of vaccine mistrust. And when we try to see if race predict vaccine mistrust, yes, racial background predict vaccine mistrust. But when we separated each group of race, only Black people were, like, being Black was able to predict vaccine mistrust. And in fact, it's being a Black person accelerate the vaccine mistrust. So it is something that is important to note. Then we also explored a vaccine uptake, and as you will see, Black people and Indigenous people are the two groups with a lower level of vaccine uptake. And it is interesting to see Asian people are the high. They have the highest proportion, and also Arabic people have a great proportion. But yesterday night I played a little bit in the data set to see something. When you try to see when people were vaccinated, you will see, like, Arabic people, if you had that study at the beginning of the vaccination, they will have the lowest level, and then after months they were vaccinated. So that kind of aspects are important to explore also. And for Indigenous communities, they were always, in Black communities, they were always part of people who were less vaccinated. But also when we asked them about access to vaccination, and people from the Black communities said they had less access at the first beginning of the vaccination process. And in the neighborhood they are living, they had more vaccination center at the first beginning. And then after, the government brought in the communities vaccination center. There was also something else I noted I wanted to share it is about the fact that when we cross the data, if you are about religion, if you are a Muslim person and Black Muslim person, they are less vaccinated than those who are Black Christian, and if they are a Black woman and Muslim, they are really less vaccinated. And when you ask them, and if you try to see, there are people who experience more racial discrimination, everyday racial discrimination, but also more major racial discrimination in the healthcare system. Black, women, Muslim. So that kind of things are important. And I said vaccination, but it is education level. And there also, you can see there is, I did not put the p-value, but there is no a difference in the last level of education. So I think that kind of things are important. And when we look at the odd ratio, if you look at the unadjusted one, you will see. Oops, I'm sorry. You will see. It's supposed to be that one. Okay, you will see difference, significant difference for Indigenous people, but also for Black people, and we have a better odd ratio for Indigenous people, like better. It is higher in Indigenous communities than Black communities. But when we try to have the adjusted odd ratio, only Black people are significant. And it is why it is important also to have to analyze separately people from the Indigenous communities to see what kind of challenges they are facing. And we will be able to do it. We have an Indigenous colleague. We will work on this. Again, we explored different aspects, vaccine confidence to see if this predict vaccine uptake. And yes, it predicts vaccine uptake. And even the role of conspiracy theories, because conspiracy theories is the best predictor of vaccine non-uptake. But when people have confidence in COVID-19 vaccine, even you put conspiracy theories in the equation, the model, it is still significant. It is one of the most important thing for us. But also, what we see when you put everyday racial discrimination as a moderator, it attenuates the role of vaccine confidence. So even the person has vaccine, those who have vaccine confidence, if they experience everyday racial discrimination, they are less vaccinated. So that kind of data are important. And then for that préliminaire, alors je vais le dire en français. Primary analysis, for me, it was important to see what kind of implications we have for research, but also for training and other aspects. And for research, for us, it is important to evaluate aspects related to conspiracy theories, because we always say, okay, conspiracy theories in Black communities, for example, in Indigenous communities, for example. But it is important to better explore the factors, to have research on factors related to conspiracy theories. And I was able to, for example, just explore, for example, racial discrimination. And one of the things that is important is to see also the historical aspect of oppression and racism in Canada, and also for health literacy, because even Black people who are nurses, for example, they declared less health literacy than the other nurse in the white communities. And we have to know about this because in the Black communities, even those who are working in mental health, they don't want to receive care for mental health. And I say even, but there are people who are discouraging other Black people to have access to mental health. And why? Because there are people who experience racial discrimination in the healthcare system, but also they observe racial discrimination Black patients are facing in the healthcare system. But also there is an urgent need to conduct research on consequences of racial discrimination on health behaviors. And I think that part is important. But also we need micro research, some qualitative micro research to also understand the dynamics behind this kind of aspect. And also to the urgent need of collecting race-based data in the healthcare system, because we are talking about vaccination, but there are a lot of things we know nothing about them, and we need that kind of data. And just Nova Scotia launched a pilot a project, but here in Ontario and in Quebec, where about 80% of Black people are living in Canada, we need the healthcare system to collect racial data. And also, I think in terms of training, there is a role here for the universities, because you cannot enter in a university and when you graduate, you become more racist than when you entered. And we have to ask that kind of questions. What happened in the university level? Why Black students are still doing their project alone, and other Indigenous students also? And we need to know more about all of that aspects. And for me as a professor, I think we have a role to be sure like no one can be graduated without a solid training, but also experience with racialized communities, without a solid training on how to treat people fairly, how to provide safe care. And also for health institutions to train their patients, their workers. And then for policies and public health strategies, I think it is important to stop the colorblind approach, because in Canada we have that colorblind approach, and people usually say, "I don't see your skin color. I see a human being." And usually I say, if my skin color is part of my problem and you don't see my skin color, it is a racist attitude. And you're supposed to see my skin color and to see, and sometimes you have some people, they start the marathon at kilometer 0, and there are others who start the marathon at kilometer minus 100. And you cannot provide the same to them if you want to address things fairly. And also, it is important to stop infantilizing the racialized and Indigenous communities. And sometimes we are trying to do things, but we reinforce racist stereotypes in everyday life of these people. And it is also important to adapt culturally adapted approach, but also anti-racist approach. And I can think about a project led by Cécile Rousseau in Quebec, for example, where they were able to work. And when we had that project, it was important to work with the pastors, with the imams, with the priests. And when you work with that people, they give you access to the communities. They give you also access to the trust of the communities, and they can listen to you, they can hear from you, and they can walk with you because they they see you are working with people they value. It is that kind of things that is important. But also, because of the vulnerability of the Black people, it is important now to have a Canadian health plan for Black people. I think about breast cancer. I think about prostate cancer, about cervical cancer. It is a whole. It is something that is systemic, and that is structural, and we cannot just treat it like vaccination. It is not just vaccination. It is something that is more systemic than that. And for the communities also, it is important to improve the implication of the communities, to work directly with them, and to know that each community matters. Why each community matters? Because what we saw, and there's an article that will be published maybe during the weekend or next week on the experience of racial discrimination in the healthcare system and health behaviors, and health behaviors, mental health, and other aspects. And vaccination is part of it. And what we saw is the fact that racial discrimination in the healthcare system is a major public health threat. It is not just a public health threat for Black people. It is, yes, for Black people, first of all, for Asian people, first of all, for Indigenous people, yes, for Arabic people. But it is a major threat for the general population. Think about Ebola. And when we talk about Ebola, if you are not vaccinated and you have Ebola, even you are Black and whatever, you are a threat for the world population. And this is what we are talking about. And when we have all of this, it is important to know that what is important is to liberate the system. Equality is good, but equity is better. But what is important is to have a system free of racism, a system where people, whatever their skin color, they can have the care they deserve, but also whatever their skin color, they can have access to health instruction, health messages in their own culture, and when we will do so, they will know their culture matters, their color matters, and even they are Black, even they are Asian, even they are Indigenous, they are really considered as Canadian people. Thank you.
Thank you very much. Donc, des présentations très enrichissantes, n'est-ce pas? Donc, on a très peu de temps. Je pense que peut-être 2-3 questions rapides, commentaires.
Oui, bonjour, je suis Luc. Je vais poser la question en français. Merci, professeur Cénat. Tu parles de libérer le système de santé. Mais je crois que, parce que nous avons parlé du fait que la discrimination, l'histoire d'oppression qui a duré des millénaires peut-être, est en train de contribuer au manque de confiance. Et moi, je crois que la pièce qui manque pour libérer le système de santé, ce sont les politiciens. Les Nations Unies, les pays occidentaux, surtout les multinationales, qui d'une certaine façon sont en train de faire du mal dans des pays en développement, qui poussent les populations de fuir leur pays. En fait, lorsqu'ils arrivent ici, ils ne mettent pas la différence entre les mesures de l'OMS et les Nations Unies, qui ont d'une certaine façon contribué à l'instabilité dans leur pays. Je crois qu'il faudra que les politiciens comprennent que l'humanité est en train d'arriver à une maturation. L'information est en train de circuler. On ne peut plus cacher les mauvaises politiques au cachet. Les multinationales qui allaient voler les ressources dans les pays africains, même les villageois sont au courant, ils le voient. Et ça circule beaucoup avec les TikTok, l'information circule. Je crois que le temps est venu pour qu'on fasse un effort pour que les politiciens jouent leur rôle, pour qu'il y ait un équilibre dans le pays. J'ai dit même pendant la pause que si nous voulons décourager par exemple la fuite des flux migratoires de l'Afrique à travers la Méditerranée, une des solutions est simple, que les multinationales stoppent d'aller piller les ressources. Beaucoup de populations vont rester dans leur pays et ça va probablement peser moins sur le système de santé dans les pays développés. Je crois que le moment est arrivé pour que ce débat soit sur la table et qu'on se regarde les yeux dans les yeux. Voilà mon petit commentaire.
Wow. Malheureusement, il n'y a pas de représentant du gouvernement ici. Un autre, d'autres commentaires?
Hi, I'm Takwa from Public Health Agency of Canada. So I have a question. Nice talk, Dr. Cénat. So I want to ask in English to take into account the majority over here. So you have noticed that you have seen that lower uptake, COVID-19 uptake among Black and Muslim, and when you added another layer of indicator in your analysis by taking into account gender, so you have seen lower uptake among women, Black, Muslims too. So wondering, have you had a chance to explore the same pattern, if it's the same thing that happened for white? So that means that it is among white Muslims, and then when you stratify by gender, taken into account gender, have you seen also the same pattern among white Muslim women too, in terms of vaccine, COVID-19 vaccine uptake? That could be a good indicator for religious and ethnicity interplay too. That would shape vaccine uptake among these populations.
I'm sorry, I was not curious enough to do it, but it is a good question. It is something to do. It is something we could do live, but let's say I will answer the question to you personally, but it is really something to explore. And usually that kind of data, we explore them after the publication of articles, and I think we need to have an article on this kind of considerations to better explain vaccine uptake. Yeah, I will explore it. And also to say other things we did not have time to explore and we will explore during the next month is data on recruited among parents with children aged 0 to 12, and we have the same data we have on I presented. We have the same data on more than 2,000 people. So we will explore that data also in the next few months.
I have a question for Dr. Liu. Dr. Liu, in your presentation, you mentioned something quite important in terms of, it's something that spills over in the community that fuels mistrust in terms of what the mRNA vaccines do, especially with myocarditis and other conditions. I know that it's not a huge problem, but the reality is that it is there. I mean, the subunit protein vaccines are not just limited to COVID. We have hepatitis B, maybe HPV, but the other vaccines, there's really not much mistrust. But now, the mistrust that comes from COVID, I believe Dr. Cénat mentioned that quite a few times too before in other sessions, is that it's spilling over to other vaccines. So what do we do now in order to safeguard the community against having a widespread mistrust, not only in the COVID vaccine, but all the other vaccines?
Yeah, very relevant question. We, in fact, in our survey, even asked the questions like, would the mRNA vaccines accidentally introduce COVID? And also, of course, people think that Bill Gates, have microchips in mRNA, and that there are a few, individuals definitely do believe that. So there's no question that when there's new technology, it comes with distrust. And I think this is a situation in which we need to use multifactorial approaches, like is really well discussed here. So one is we need to have objective data, right? So the reason we did the myocarditis is actually to show that, in fact, even though there is concern, in fact, the data does not support it, it's actually safer. But then it's also super important, as well illustrated, to engage the community in a trust manner, right? So this is where working with community leaders, like you folks are, working with religious health leaders who are trusted in the community. For example, when we do the surveys, we make sure that the surveyors, the folks who are actually conducting the survey are all from the community, so that there is that layer of trust to start with. But I think the more that we can actually build on these community-based, cultural-based, it could even be, sort of socially based programs in which we can actually transmit the information. And then once, people see that others have done fine, after the vaccination, there's that sense of relief as well, because people generally will fear the unknown, and this is all kind of natural. But I think combining science, with all the social cultural aspect, is so important. Yeah, as discussed here. Yeah.
We have a last question. Yeah.
Oh, thank you. Sorry, Dr. Liu, but I wanted to hit you up with this as well. As I said to you, I was really amazed that these barriers that you identified really mapped perfectly onto what we identified in a scoping review of 100 studies from Canada and the US. But what I'm wondering is, and I may be overinterpreting your data at this point, it seemed like, so one sort of slight surprise, let's say, is that there's certain, not really, but it's not been shown that much. There's also vaccine hesitancy, and there's lack of confidence in white populations too. But it seemed like one of the biggest orders of magnitude of difference was in the much lower rate of barriers and access to vaccines among white populations than all the other racialized populations. And I wondered then if that's potentially helping to explain a story of why uptake might still be higher among white people. It's not really, we have to look at it in a kind of multifactorial way, that part of it is hesitancy and lack of confidence, lack of trust, but buffering that is barriers, and that if we can also somehow address those barriers among racialized communities, even if the level of mistrust, and I'm not saying that's good, but remains the same, we would increase uptake of vaccines. Is that reasonable?
Yeah. Yes, absolutely. And thank you for your comment. That's reassuring for us as well. And but I think it comes down to, for example, some of the diagrams that Professor Cénat has demonstrated, right? So yes, you can actually have the same, it really actually shows that there are different pathways and different factors. In terms of the phenomena of mistrust or, vaccine hesitancy, there are these contributing factors, which could be cultural, could be, sort of a social, and it could be, sort of experiential. But on the other hand, the data from the white population actually give us, I guess, on one hand, kind of interesting insight, but also hope as well, right? It does actually indicate that, in fact, there is mistrust, likely from social media, from, all these novel technologies that we have, and that contributed to that, misinformation, etc. But on the other hand, you can actually tweak the system such that you can actually overcome that. Right? This is where you actually look at all these different groups, begin to provide that important insight. So then you can then realize, addressing the source of the mistrust, but also allowing the system to overcome those barriers, you can achieve the best of all worlds, right? But it's really dissecting out this that really allows us to do that. Yeah, so thank you for your comment.
Okay, so thank you very much, everyone. Seriously? Just the time, so no problem. You will just try to shorten your.
Thank you so much, Dr. Sarai. I was raising my hand in vain. But I guess my question was related to your slide talking about the indicators for vaccine mistrust. So you had this box flow chart about conspiracy theories being one, but you mentioned that being Black was in itself an indicator of mistrust. And I guess kind of connecting to some of the other themes that we've explored in the other presentations, how do you sort of, going back to an earlier question about knowledge translation, when you engage in these communities and you share this data about how being Black is an indicator of mistrust in itself, how do you go about approaching and connecting and communicating with these communities without sort of infantilizing, as you mentioned in your implications section?
You can start.
The first thing is there is a real challenge in the Black communities now. People are tired of speaking about vaccination, but also even about mental health, about racial discrimination and other aspects. Even all of this, what we did was to speak to the leaders. We had multiple, about 20 workshops and events where we spoke about the results, we discussed them, but also we see with them what we can do to better reach out the communities. And what we found was, for example, to better tooled the religious leaders and the community leaders to be able to do it themselves, and this is what we did. And also the Black health professionals, because it is not because they are health professionals they know about that kind of results and they are really able to do that work. And when they have more information, they can do that work. They can better do that work. And this is also why we had some workshops with Black health professionals. And there is also an association of working multiple, not just one, because there is the one, the CADO, the Canadian of African Descent Association, but also there is the one in Nova Scotia, HAC, and we spoke with them, and it was interesting to bring that kind of results. And what they are able to do now is to take this into account also when they are developing their own project. And the HAC, for example, they have a project they have multiple projects on vaccination, and they were able to ask us to analyze the data for Nova Scotia because they are intervening more in Nova Scotia to analyze the data in Nova Scotia for them. We did it for them. Also, what we did was to work with public health agencies. For example, Ottawa Public Health Agency, they are part of the things we are doing. We had meetings with the boss, Dr. Vera HS, and they are part of what we are doing. Like, they know what we are doing, and they can, if they want things, they can ask it to us also. We did the same for Nova Scotia Health and Ontario Health. So we are working directly with people who are implicated, who are involved to try to change the things. But we have to recognize that what is the most important is to prevent, and the way we can really prevent things is to liberate the system and to make the system free of racism. And it is unacceptable when you are going to an hospital to take care and people discriminate you. And what we are talking is about. It depends of the study, but if we consider all the studies, at least more than 30% of people from the Black communities will say they experience major racial discrimination in the healthcare system, and sometimes it is more than 60%. So it is unacceptable. Yeah, and this is my will to thank you for. Can you please make a round of applause for all of us? Thank you. Thank you. I will be honest. I started the day a little bit sad because we rejected a lot of registrations because we were sold out, and a lot of people who registered did not come. So it was a little bit sad for me. And then we had the presentations, and then I saw the results and I said, oh, cool. And there is space to really change there is space to change the system, because there are a lot of people who are thinking about the things. We are work on the things, and I was happy to hear all of my colleagues, and I want to thank each of them, Dr. Vang, Mrs. Gay, Monsieur Gilbert, Dr. Dubé est déjà parti, Mrs. Tsui, I'm sorry. Peter Newman, Dr. Peter Newman, Dr. Aisha Jua, but also Maddy, and Maddy is doing a lot of analysis. And even when we were on the table there, we had an idea, and I asked Maddy, "Can you just see what we have?" And we saw it, and it was a great result. And also Dr. Meyer and Dr. Peter Liu, I know Dr. Peter tell you how busy you are in taking that time to come and present your data, and it was very interesting data also. And I want to thank Public Health Agency of Canada to fund us, because without this kind of funding, it will be impossible to record this kind of data. And I can tell you, 5 years ago, when we launched the project on Black mental health in Canada, I said we will recruit data, we will collect data on more than 800 Black people. And people told me, no, it is impossible. And I had some colleagues at McGill University, they did not want to be part of the project because they told me, in the last 30 years, Jude, we tried, it is impossible. Today, even these colleagues, they are calling, asking, oh, Jude, you do it, we can do it, what we can do. And we were able in that project to collect data on 1,300 Black people, and now we developed the concept of peer research associates, and we were able to collect data on more than 2,000 Black people. And now we worked with, when we approached Leger marketing for the data collection, they told us it is impossible. It is important to also see to put also peer research associates for each community, because we are unable to collect this data among all of that people. And we work with them to develop the tools, and to have the tools culturally adapted. And I can tell you, we were able to collect data on Asian people, Indigenous people, Black people, more than what we expected, more than what we asked them. So things are possible. Continue to think, continue to work. For those who want to change the system, I would say see you at work. And the most important to know is, together we are the solutions. Thank you, everyone.